and welcome to my channel. I am Jess and I wanted to make a full long video on juvenile arthritis as kind of like your complete guide to arthritis. And if you have a child diagnosed with juvenile arthritis or you're diagnosed with juvenile arthritis yourself, you're new to it, don't really know what's going on, this is kind of the complete video. Hopefully I'm going to cover everything. If you see me looking off to the side, I've got my iPad with my notes. I'll start off by introducing myself. Hi, I'm Jess. I'm 18 years old and I was diagnosed with polyarticular juvenile arthritis at around 16 months old. So I've been living with this condition for a long time. So I think I can give a pretty good scope of what it's like to be diagnosed with juvenile arthritis and dealing with it as a condition. JIA stands for Juvenile Idiopathic Arthritis. Juvenile meaning that it's diagnosed before 16 years old. Idiopathic meaning that they don't know the cause. And arthritis is the type of condition. It's an autoimmune condition. It's also an umbrella term. An umbrella term is something that is kind of like a category. So it has lots of different subtypes, but most people will just tell you, I have JIA because it's easier. So there are 6 subtypes. I might butcher the name of some of these because they have very difficult to pronounce names, but I'm going to do my best. There is Idiopathic JIA, polyarticular JIA, enthesitis related JIA, psoriatic JIA, systematic JIA, and undifferentiated JIA. So firstly, let's just get things clear about JIA. It's an autoimmune condition, which means that my white blood cells are attacking my joints. So it's a bit like they get confused. So there's viruses and then there's your cells that make up all of your tissue, bones, muscles, anything that's in your body is made up of cells. And the problem is that the white blood cells cannot tell the difference between a virus or an infection and the cells in your body. So it kind of just attacks everything blindly almost. And arthritis usually affects joints. However, the different subtypes affect different things. So I will go into that now. The first type of JIA is Idiopathic. This is the most common type. It affects 4 or less joints, and it most commonly goes into remission after 6 months. However, sometimes it goes on for longer than that, and then it's called persistent. So if you aren't common with the phrase remission, it's something that I'm going to be using a lot in this video. Remission is when the disease goes dormant, so it almost goes to sleep kind of, and it goes back to normal sort of. So the most commonly affected for Idiopathic is knees and ankles. So that moves us on to polyarticular JIA. That's a type that I have. Polyarticular JIA affects 5 or more joints and occurs for an extended period of time, so it usually occurs for more than 6 months and keeps going. It's less likely to go into remission, but it can go into remission. So most people with polyarticular JIA will just have to learn how to manage their condition, as it's more likely that they're going to be living with it for longer periods of time. We'll move on to the next one. Enthesitis related JIA. This affects the body slightly differently than the first two, because it causes more inflammation in the tendons rather than just in the joint. So it sort of is in between the tendon and the bones rather than sort of lining the cartilage and the bones. Next is psoriatic JIA. This is where a condition called psoriasis comes alongside juvenile arthritis. So psoriasis is a skin condition that is, again, it's autoimmune, and it's where the immune system attacks skin cells, so it causes sort of red, blotchy, almost like a rash marks on the skin, and they usually coincide, so you'll get some joint swelling like you would with polyarticular JIA, and you'll get some psoriasis along with it. I think a lot of people with psoriatic JIA tend to get it in the same place that they are struggling with their joints, but it can come along sort of almost separately, but they do occur together. Next is systematic JIA. Most people refer to this as SJIA. SJIA affects the whole body rather than just the joints. So it affects the joints just like it would with polyarticular JIA. However, the immune system can attack anything. So it can attack your internal organs. It's more likely to attack your eyes than other types of JIA. So, and it also causes more symptoms like fever, rash, sickness, more than regular sort of polyarticular JIA, because it's affecting your whole body rather than just your joints. And most SJIA patients stay on treatment for all of their life. And the last is undifferentiated, so that's where they can't really differentiate what type it is, but they know it's some sort of JIA. The good news is there are a lot of treatment options. I will try and run through them all as briefly and as quickly as I can, and I will put stuff on the side of the screen here. So the first thing is disease-modifying anti-rheumatic drugs. These are sort of they have less side effects than other drugs, so they're usually tried first. So these are drugs that you'll find like methotrexate and leflunomide. However, they don't work for everybody. They work for maybe a handful of people. So if that doesn't work, they will try you on a mixture of these drugs and biologics. Biologics suppress the immune system. So by suppressing the immune system, they're basically putting the white blood cells to sleep so that they cannot attack anything. However, this does mean that they cannot attack viruses and infections. So you or your child will probably be catching a lot of colds and might be taking a rather long time to recover from it. However, they do tend to work pretty well. Unfortunately, these are usually injections, and it can be a bit difficult to adapt to injections or inject your child. However, it is something that you do get used to. If it might seem a bit scary at first, that's okay. But it is something that you get used to eventually. And it is a lot easier than when my mum had to learn how to do injections for me. You now have so many different options for injections. So there are injector pens, which look like this. And sometimes they'll have a button at the top, sometimes they don't even have a button at the top. And they work like an EpiPen. You take both of the caps off, put it in leg or stomach, and click a button, it clicks, you see like a thing slide down, there's a little window in it, which again I'll show here, and then it'll click, and once it's clicked, it's done, take it out and throw it in a sharps bin. Nice and easy. Then there are syringes, pre-filled syringes, so that's quite literally take the lid off, insert needle into leg, push it in like a regular syringe. There are actually auto-injectors being developed at the moment, and you basically just place it on, click a button, and it works it out in the system and does it, and then you take it off. So you barely have to do anything really. So there are quite a few options. You just sort of have to see what suits you. There are also these things called buzzy bees. I will again put a picture here, and these, they're like, it's like a little ice pack that has a vibrating bee. You stick it on wherever you're going to inject, so your leg, stomach, and it buzzes with the ice pack, so it numbs the area to do it, because they do tend to be quite painful, they sting quite a lot, I will warn you, but it does help. So if you're struggling to inject your child, or you're struggling to inject yourself, I recommend one of those. I've tried one of those in the past, and they worked out pretty well. Something that you do have to be very careful of when taking immune suppressants are things like all of the side effects. So you'll get this big scary sheet that has all the side effects on. For your own comfort, maybe don't read it, because it can be a bit scary and they don't happen most of the time, the side effects on there. However, when taking things, I think it's especially things like methotrexate, when it's sunny out, make sure you're wearing sun cream, because it can make you more susceptible to sunburn and skin cancer. So sun cream is a must. Always wear sun cream when you're out if you are on biologics. Next drug is non-steroidal anti-inflammatories. These are things like ibuprofen, naproxen, piroxicam, meloxicam. They all come in the same group as ibuprofen. So you'll be familiar with ibuprofen or Nurofen, and it's just an anti-inflammatory. The other ones after ibuprofen are just stronger versions of ibuprofen, kind of, and you take those when in a flare, as and when needed. So if you've got a swollen joint, the first thing that you'll do is start taking anti-inflammatories. If it doesn't go down, you then call the hospital and let them know that you're in a flare. The next drug is oral steroids. So you would take them as a course. Usually it starts with something like 8 tablets for 5 days, and then lowers down to 4, 2, 1, all in the course, and they usually tend to work quite well for if you're having multiple joints flaring up. That's sort of what they will go for. However, they don't always like to give out oral steroids often. So if you're having flares often, it's not the best thing to go with. So the next thing are steroid injections. Steroid injections, or joint injections as people call them, you would go into hospital when you're having a flare, and in the joints that are swollen, they will inject steroids. Steroids are very, very effective at sorting out inflammation and flare, and there are 2 different types of steroid injections. There's one that lasts for 3 months and one that lasts for 6 months. The one that lasts for 6 months is usually in short supply, so usually if you are a younger patient you tend to get that, rather than if you're an older patient you will be stuck with the 3-month one most likely, just because they are in such short supply. And this usually keeps your joints good for either 3 months or 6 months. When they are doing steroid injections, they may also aspirate a joint. An aspiration is where they will take some of the fluid out of a joint. You may end up with a knee twice the size it's supposed to be, and it will all be filled with fluid. They will get a syringe and take some of this fluid out. They might take it for testing to see if there's anything in particular that sets it off, and then they will do a steroid injection after aspirating, just to sort of relieve the pressure a bit more quickly. The couple of days after a steroid injection you will be very sore. If you've had it in your lower joints you might struggle with walking, and you'll have to just sort of build up walking again. One thing I will say about having a steroid injection in any joint is the few days after it, keep your joints moving as much as possible. Obviously swelling restricts movement, but if you can keep your joint moving as much as possible, it helps to sort of spread the steroid around and helps it sort of get to all of the parts of the joint so it works better. The next thing I'm going to be covering is hospital appointments. There are 2 types of hospital appointments. You have a routine appointment and a flare appointment. Routine appointments, they are usually every 3 months, just to check progress, how things are going. If you're doing quite well, it might extend to every 6 months rather than every 3 months. So the routine for routine appointments, you will get there on the day, wait in a waiting room. They will take you in for height and weight to check how you're getting along. Sometimes immunosuppressants can stunt growth, so they just like to know how you're getting on with things really. Then you will go back into the waiting room and they will give you a questionnaire. This questionnaire has the same questions on every single time you go. It will have different sections. So the first section is how are you or your child doing things at the moment. So it'll have things like running and playing as like somewhat able to do, completely able to do, unable to do, with difficulty, or non-applicable. So it would be non-applicable if your child was not running and playing yet, for example. It has lots of questions like that. So it has questions about normal activity, bathing and dressing, and a basic evaluation of what can your child do and what can't your child do. The next part of it will be, how is your pain today? How has it been in the past week? They'll give you a scale. They'll be like a scale, 0, no pain, 10, the most pain you've ever been in. Get used to that scale because everyone will ask you about that scale. 1 to 10, how much pain you're in. It gets frustrating the amount of time that you get asked that question, but you kind of get used to it and you learn sort of what your baseline of pain is. Something that I will say is, when you're saying the normal amount of pain, you have to make sure that you're being clear that your normal amount of pain on a day-to-day basis, what number is that? Because the normal amount of pain should be 0. And if you have arthritis, I can guarantee that on a day-to-day, you are not living with a 0. So most of the time I say that my baseline is around a 4. I'm in pain day to day, it's manageable, I'm still able to do everything I want to do, but it's, you know, manageable. When I'm in a flare, it would go up to more of an 8, let's say. So you kind of have to just adjust and get used to where you are with that. If your child is non-verbal, as like if they're too young to speak or they haven't started speaking yet, it can be a bit more difficult with this scale. You either just don't complete this scale, or you explain if they've been crying more than usual, if they've been crying less than usual, if they've been doing more of their behaviours when they're in pain. You kind of adjust to learning where that is. It does get easier as your child gets older. You would then give this questionnaire to your doctor who you're seeing in the appointment. It's usually going to be the same doctor each time, or it might alternate between 2 or 3 doctors each time. And they will just track your child's progress, how they're getting on, what they might need. And the next thing that they will do is a physical examination to see how all the joints are behaving. And they tend to do this in paediatrics but don't really tend to do this in adults, because it's harder for children to say what hurts or what doesn't hurt. So they have to do a more thorough examination. So they will kind of get you to do this whole routine of, they will check your hands, they will go through like a whole routine, check your elbows, check your mouth, legs, knees, ankles. Basically every joint that you've got in your body is checked. And then they will sort of evaluate how the child is doing, whether the medication that they're on needs to be changed or not. And you'll go from there. The next type of appointment is a flare appointment. So this is where you will call your team up and say, me or my child is having a flare, so we think we need assessing and joint injections or steroid like tablets. In terms of other appointments, your child may have physiotherapy appointments, regular blood tests to monitor the condition and check for any side effects like liver function, kidney function, check that they're all going okay, and that the medication isn't causing any issues there. The next section of this video is managing school and sort of letting school know about JIA and how to go about that. So schools should give you a medical care plan to fill out. So this is where you would include that your child may need to be having ibuprofen, paracetamol, or the other types of anti-inflammatories that are in the same group as ibuprofen. And they will keep those in the first aid area, but they need to have a record of that's okay to keep in school. And the next thing that they'll fill out is that your child will probably be having more time off school than regular children, because they might need time off for appointments, they might need time off for feeling unwell, they will need more time to recover from things like illnesses like chickenpox, colds, flu, whatever. And that those will be authorised absences. If they put those down as unauthorised absences, you can report that for discrimination. You may also want to note down that your child may be using mobility aids, or they may be wearing different shoes than the uniform, or different uniform entirely, because you might need things to accommodate. So they might struggle wearing, say, school trousers if they're having a flare, and it might be more comfortable to have tracksuit bottoms on or something. So again, that you can write that down. I found that primary school is a lot more accommodating to these needs. I struggled a lot more with this in high school. And they still have a medical care plan in high school, it's the same. It's just that the rules in high schools are a lot stricter, so they can be a bit more difficult about things like this. I found high school very, very difficult personally, due to them just not being very accommodating for me. This is more for any teen sort of age JIA people watching this, is that you may end up getting told off or possibly being given detentions for things that are not your fault, like being late to class due to not being able to walk properly or not wearing proper school uniform. As long as that is written down in your medical care plan and they have gone against it, you can report that, and you don't have to be afraid to report that. It's something that I was always too afraid to report, and I wish I had reported it. So please, 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 please do report them if they are sort of giving you any sort of discrimination for the things that you need due to your medical conditions and everything. And I think socially as well, primary school was a lot easier than high school. I didn't tend to tell people in high school that I had juvenile arthritis, as I didn't really want to seem different from other people, which is something that everybody goes through. It's not just a sort of medical condition thing to do. A lot of people hide things about themselves in high school to try and fit in. It's not something that you especially need to hide, and it will be hard at times to hide it when you're having to use things like crutches, but it's completely understandable if you don't want to tell people about that. But it is important to let the actual school know that you have a medical care plan, even if you don't really feel comfortable telling your peers in school about it. Mobility aids are very, very helpful, and this is coming from a more sort of 17-18-year-old Jessica speaking than my smaller self. I was told a lot that mobility aids, you shouldn't really be using them, you should be trying to use your joints to the full ability, but they're not always going to have the full ability, and it's not a bad thing to use mobility aids. It's something that needs to be talked about more, I think. That it's really not a bad thing to use mobility aids. If you need to use crutches, use them. If you need things like a walker, if you need things like a rollator or a wheelchair, it is not a bad thing to use them. It is not giving up to use them. If it means that you are more able to do things that you want to do, it is definitely not giving up. And it is very, very important to know that you are not just giving up on your joints entirely by using a mobility aid. And it's also okay to use mobility aids as and when you need them. Some people worry about that they shouldn't be using them because they don't use them all the time, but arthritis is a condition that flares, so sometimes you'll feel absolutely fine and sometimes you will need that bit of extra help to do all of your daily activities, and mobility aids is the way forward with that, and it's definitely something good to be used. And for any adults watching this for their children wondering about this, and they may be told that it's not a good thing to let your child use mobility aids, or you'll worry about being judged for, you know, having a child use mobility aids. It's harder for you than it is for your children. As a child, I used crutches and I didn't really care that much. It meant that I could get about faster, it meant I could get about easier, just like all of my friends at primary school, so I didn't find it a strange thing, and especially younger kids don't really have an ableist viewpoint, so your child won't be seen as different. As long as they can still be included in games and stuff, they won't be really seen as different. I wasn't really seen as different in primary school, just because I used crutches every now and then. It wasn't too big of a deal to me, and I sort of didn't really feel it to be too much of a big deal. But I do realise now that I'm older, it can be more difficult for the parents than it can be for the children, as adults are more socially aware of what other people think of them, that children don't really have that viewpoint yet. So it might be harder for you watching your child use a mobility aid, but it is something that you get used to. And if it means that they can enjoy more of their life, then it's definitely a good thing to have. So if your child needs a wheelchair when on holiday, then that is a good thing to have, and it's not giving up by like giving up on walking, because it's not giving up, it's just a way of making their life more accessible to them. In terms of the future with arthritis, it goes very different ways for different people. Some people go into remission and they live completely normal life, and some are needing surgery to repair some of the damage that arthritis causes. And I think arthritis damage does need to be talked about a little bit more, because it wasn't really something that I think me or my parents were aware of when I was younger. There was sort of a bit less research into it then as well. But I'm going to put a diagram here. The top is a healthy joint, and you can see that the bones are looking smooth. There'll be healthy cartilage, healthy tendons, and a small layer of fluid to lubricate the joints. And the bottom part of this diagram is a damaged juvenile arthritis or rheumatoid arthritis kind of joint, which is inflamed. As you can see, there's more fluid and the bones are chipped away, and there might be less cartilage than there's supposed to be, because it gets wasted away a lot quicker than bone does. And these things can need surgeries, so you might have fusions. So a fusion is something where they will put a screw in a joint, so usually in an ankle they'll put a screw in there, and the bones will come together as one, so you'll kind of have a bone like this is your leg and that's your ankle, and it'll stay like that kind of, but it reduces pain. I've had a fusion. It didn't go quite as expected for me because I have other health conditions as well as juvenile arthritis, but I know a lot of people where it has gone very well for them. So there's definitely things that can be done about arthritis damage and managing arthritis damage. One of those things can be mobility aids as well, to take pressure off joints, using crutches, wheelchairs. They're all helpful to do if you're having a lot of pain daily. If it means that you can do more by using a wheelchair or crutches, by all means use wheelchairs and crutches. At the moment, the only thing to be done for arthritis damage are surgeries like fusions and replacements and other sort of corrective surgeries, but I'm hoping that there will be advancements in the future to sort of slow this sort of progression down so it doesn't happen too quickly, so that you're needing replacements when you're older than 17. And immunosuppressants and biologics, disease modifying drugs, they're all the way forward with this to stop this damage from happening. And there are big advancements coming in with that, which I am personally very, very interested to see how that comes along. Some of the things that are being talked about with arthritis research are really interesting for me at the moment. The last thing is transition. So the last thing with being in paediatric care is your transition into adult care. It can feel very, very, very strange when you've been in children's for a very long time. I was in children's for 17 years. And they did keep me a bit longer than they wanted to, just because they just didn't find a right point to transition me at. But the talk about transition started at about 14 for me, so they speak about moving into adult care, so they give you plenty of time to process that and sort of, you know, get yourself ready for that. You might also be given a youth worker. Youth workers are great. I've had great experiences with them. They are very, very, very helpful. And if you have any worries about transitions into adulthood, they're definitely the people to speak to, because they will guide your transition. In the transition, you will tend to have 3 things to work through. So they will ask you about how you're managing your condition. So they will ask you a series of questions, or give you a sheet with a series of questions like how much do you manage your own medications, how much do you manage your hospital appointments, do you feel comfortable enough that you'll be able to go to hospital appointments alone, and everything like that. They will ask you and track your progress. So they'll probably first ask you when you're about 14. And at that point you might not be managing loads of stuff by yourself, but you might be managing a few things by yourself. And then at sort of 15, 16, they'll ask you these same questions again, and they will start the transition process between 16 and 18. They don't really want you in paediatrics past 18. So the transition usually is around 16, 17, which can feel a little bit strange going into adults when you're used to children's. There's a lot of things that you have to get used to that are different. So the difference with appointments I've found with rheumatology in adults is that you don't see your doctor all the time necessarily. When you have a routine appointment, you see a registrar. They are kind of like a consultant, but I think they're just slightly less trained than a doctor. I'm not exactly sure what the difference is, but they're knowledgeable about arthritis, but you'll usually see a different registrar each time, but you'll have one primary care doctor that when you tell things to a registrar in an appointment, it'll be fed back to them, and if you're struggling you will see your primary care doctor as well as the registrar. But it's just to make appointments a bit quicker, as they have fewer doctors in adults, I think. It does feel very strange going from paediatrics to adults, because you will feel like the youngest one there, and it does feel strange, but you do get used to it eventually, and you will end up getting used to calling to make your own appointments and sorting out your own medications. But you do that slowly as a process. You won't be thrown into it all at once. They will make sure to do it slowly so that you don't feel like you're thrown in the deep end. And just because you're in adult care doesn't mean that you can't take your parents into your appointments. Your parents can absolutely come to your appointments with you. Appointments can be difficult. It's definitely good to have somebody that you trust with you to help you out and sort of make things a bit easier for you. My dad usually comes to my appointments. I do feel comfortable knowing that if Dad was not able to attend one of my appointments, that I would be able to manage it by myself. But I do feel a bit more comfort having my dad in my appointments than just going alone, and you can do that for as long as you like. But maybe as you get older you might prefer to go in alone, and there are things that you want to discuss alone, and there's all sorts of things that they will make sure that you are comfortable doing what you're doing, so they won't make you go to all of your appointments by yourself. You can take somebody with you. I think that is just about everything I had written down to cover. If anybody has any questions about juvenile arthritis or anything else you want me to cover, I am happy to make another one of these videos. I'm happy to make shorter videos. I have the same username on TikTok and Instagram. I post stuff there quite regularly, but I am happy to make more videos about this if I've not made anything clear enough, if there's just something that you feel like I've missed completely. That is fine. I know that there is a lot to run through, and I've probably definitely missed stuff, and I'm very sorry if I've missed stuff. I've been planning this video for a really long time to hopefully not miss stuff, but there will be things that I've maybe not covered quite as thoroughly as you need to know about, so I'm happy to make individual videos about the certain sections in this video, but I kind of wanted it to be a video all in one, your complete guide kind of thing, but I am happy to make more thorough videos about different little parts that either I've experienced or you want to know about based on my research. So I hope that this has been helpful, and I wish you all the best. Thank you so much for watching.